Hi, good morning. Thank you all for joining. I'm Samantha Mokas, and I work with the Florida Association of ACOs as the Director of Member and Partner Services. We are excited for the opportunity to present to you our next installment of our free webinar series. Today, we're going to discuss Final Rule Pathways to Success for the Medicare Shared Savings Program. We have Sheila Fuse, who is also a FLAACOs Board Member with us today. Before we get started, I would like to go over a few items so you know how to participate in today's event. You should see an attendee interface on your computer desktop in the upper right-hand corner. You can listen in via your computer speakers, or if you would prefer to join over the phone, just select telephone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of the control panel. You may send in your questions at any time during this presentation. We will collect these and address them during the question and answer session at the end of today's presentation. With that, I would like to hand over the presentation to Sheila Fuse. Thank you, Sheila.
Thanks, Sam, and good afternoon to everybody. Happy Friday. So most of you, I think I've worked with many of you before and certainly have spoken at many of the FLAACOs conferences that we've had. But just to give you a little bit of background on myself, I started one of the first 27 ACOs in 2012. So I have been watching the program evolve with the Medicare Shared Savings Program, and I'm really excited to talk about the final rule today because it really represents some of the biggest changes we've seen since the program's inception. So I'm going to just kind of jump right into our materials and talk about the pathways to success. So on December 21st, last month, CMS released the final rule, and it really represents the most sweeping changes to the program since its inception, as I mentioned. And so one of the first things that CMS goal really wanted to do with the Pathways to Success is design a glide path towards risk and really to the enhanced track that has a 15% maximum loss cap. So you really want to think about that with the new final rule is there's now a clear transition to risk and pathway that everybody is on and starts at a different point, which we'll be talking about in detail today. The other thing it does is it extends the agreement period from 3 years to 5 years to really improve the benchmark stability by providing a longer period of time to measure performance against the benchmark. CMS has also made a number of changes to the benchmark methodology as well that we'll talk about today, as well as improving the ability to coordinate care for beneficiaries through waivers and incentives. So one of the things that's really important is to understand successful strategies to be able to manage risk and succeed. So you really want to be able to plan to successfully improve patient outcomes and reduce the total cost of care. That's really the goals of the program. And you want to start off by thinking about an aligned funds flow model. So what are the initiatives that your ACO is taking or that you're partnering with the ACO? What strategy do they have to be successful to be able to lower total cost of care and improve patient outcomes? And how is that strategy aligned towards achieving those goals? And then how does that align through the participants and suppliers that are part of the ACO through shared savings? So for an example, one of the successful ACO tactics that I've used in the past and many ACOs have used is really to focus on annual wellness visits. Annual wellness visits, for example, will allow every patient to be able to come in so you have an opportunity to improve patient engagement, close gaps in care, accurately document all current and past chronic conditions to improve your HCC coding, and then also establish individual care plans. By putting your wellness visit as one of your opportunities, it also allows your physician practices or health systems to improve revenue today, and then also align the wellness visits as a kind of a success measurement for future shared savings with primary care providers who would be the ones to be performing that. So that's an example of really looking to align your funds flow or your shared savings throughout, how you're aligning your ACO strategic goals to be able to be successful, and then how you align it all the way down to your participants and suppliers. You also want to think about the infrastructure to support care redesign and individualized care plans and create strong partnerships with post-acute networks. We've really found that building the care model to support care redesign for all members, not by payer or contract, really helps maximize physician and practice adoption. So it kind of goes with that keep it simple theory that's usually so successful. And most successful ACOs have built post-acute partnerships because they really find it's an area where they've been able to successfully lower the total cost of care by coordinating discharge planning and creating either care compacts or high-performance post-acute networks. And those are really some of the kind of the key things to be successful. In addition, you really want to go into the ACO contract previously, and even more important now under the new Pathways for Success role, as though you are managing two-sided risk with the aim to expand into Medicare Advantage and or CMMI's, what we expect to be released in the coming months, the new direct primary contracting model. Both of those are going to have an even greater upside, and both are going to be about being able to take on and manage risk. So enter the Pathways to Success day one as though you're managing risk, even if you're on one of the upside levels and starting. And then lastly, really think about establishing best practices for managing total expenditure, accurate HCC reporting, and quality measures reporting that aligns to HEDIS for Medicare Advantage or other payer contracts to, again, simplify it for your providers that are participating in the ACO. So just a few kind of important things to lay out for being successful under the program. So now let's start diving into the final rule overview. There's 6 major themes that I'm going to talk about under the final rule overview. So it really starts with the 2 model options. So CMS has opened up either a basic track or an enhanced track. And I really consider them as either going in having basic experience with risk or enhanced experience with risk, which is why I put risk in parentheses. So the basic track combines track 1, 2, and 1 plus and collapses them into the basic track, providing a glide path starting at track 1 that we'll go into a little bit more in detail. And then the enhanced is track 3 renamed. All of the features of track 3 are identical with the benefit of the additional waivers and beneficiary incentives. And then there's the agreement terms. So the second part, looking at the agreement terms, as I mentioned, the 5 years agreement versus 3 years provides more stability. And the other thing is the percentage of shared savings was lowered to 40% for upside year only, and then increases to 50%. So this is actually a significant improvement from the proposed rule, which most of you saw the headlines that CMS had initially proposed a 25% sharing rate in the upside only years. So again, it's starting at 40% and then moving to 50% as soon as it goes into two-sided risk years. And then the program for 2019 is going to start on an off-cycle date of July 1st and then move to a January annual start going forward. And then the third area to cover is looking at the changes to risk. So right now, the basic option provides inexperienced and low revenue ACOs 2 or 3 years as upside only. And then beginning in year 3 or year 2 for experienced participants, the ACOs move into two-sided risk that increases annually. And then the enhanced option or track, which is track 3, starts with a two-sided risk on day 1. So important to know that. And what the goal of CMS is really trying to do right now is provide more time for what they consider physician group ACOs or low revenue, help expedite the transition to risk for those who are not, who have more experience or have more capital, like health systems that they felt had more control over total expenditures, as well as achieving the goal to remove what CMS calls ACO squatters from remaining in upside ACO contracts who are not performing. Now, continuing on the overview, the other major components of it is the first thing is there was a number of improvements to benchmarks. So if you were a low cost efficient ACO and you are lower than your peers, you're going to benefit tremendously from having a regional adjustment factor that begins in year 1. And so CMS will put in a weighted blend of the regional cost. And if you're more efficient than your peers, meaning that you're able to manage the total cost of care at a lower cost than peers in the same county, CMS county, then what happens is you will actually end up having a bump up in your benchmark, because the average that goes in that's higher of your peers will actually raise your benchmark by anything from a couple $100 or more, depending on how more efficient you are. If you are a higher cost than your peers, then you get a lower percentage, but everybody will get a regional adjustment factor beginning in year one. So it's really good news for those that have a low benchmark and are efficient performers. The second thing that's significant is there's now going to be an HCC risk adjustment for all assigned beneficiaries, not just the newly assigned, and that will be on an annual basis based on health status. So that is a real positive. And then the last thing they did is CMS included the national regional blend factor to trend forward, which mirrors Medicare Advantage, the way the program works today. And then there's also increased flexibility. On an annual basis, CMS is going to offer the choice of prospective or retrospective beneficiary alignment, and it will also expand the access to waivers and beneficiary enhancements and incentives during the two-sided risk years that an ACO can apply to be taking advantage of every year. And then lastly, as it was before, there's both the MIPS and the MACRA, where the enhanced ACO track qualifies as an enhanced APM for the 5% bonus, which tracks 3 offers today, and as well as the basic ACO track now qualifies as a MIPS APM, but then will move into an advanced APM when it reaches the maximum level of risk, level E, which is the same amount of risk as track 1+. So both tracks lead ultimately to the advanced APM for that opportunity to achieve the 5% fee-for-service bonus. So those are the high level of the rule overview, and we'll go look at them in more detail. So next I want to talk about program timing. So for all renewing ACOs, the application time period is going to be February 19th. For new ACOs, the first deadline actually just passed last Friday because the notice of intent to apply was due Friday, January 18th. And so now, July 1st is going to be an 18-month performance year. So for new eligible ACOs to start in an upside only, this is going to provide the longest window of time to participate in an upside only contract. For the existing ACOs whose contracts were set to expire last December, 90% of those ACOs applied for the 6-month extension to renew on July 1st. So all ACOs who are planning to participate or renew in 2019 need to meet the aggressive application deadline of February 19th to be able to start on July 1st. Now, while CMS has streamlined the application process, ACOs may have to determine, well, they do have to determine now, the impact of the final rule in a short amount of time to participate. Many of you have probably seen the request made this week through the AMA and America's Hospital Association, the AHA, have put in a letter to request to extend the deadline to the end of March because they feel there's not enough time to properly evaluate the changes to the program and what it means to ACOs for participation. So right now the question is whether or not CMS will extend the deadline. Had a lot of discussions over this and do not anticipate Medicare to extend that application deadline. So we will wait and see how Medicare responds. But most likely, because the application process is going to return back to the January cycle for 2020, CMS should be opening up the notice of intent to apply in May. And because the cycles are so close together, I anticipate that CMS is going to say if people aren't ready to start in July, then wait until and apply for a January 1, 2020 start. So now let's take a little bit more, a look more at the 2 tracks and then really go into what the glide path means and some of the new terminology and benefit for what they call low revenue and inexperienced ACOs. So starting off with the 2 program tracks, basic and enhanced. The basic track, as I mentioned, is a 5-year glide path that starts with level A and ends with level E. Levels A and B are really the same as track 1. They're upside only without any downside. Levels C and D are 2-sided risks that step up and increase the amount of risk, similar to track 2, but with a much lower level of downside risk. And then level E is identical to track 1 plus today. And then there's the enhanced track. And with the enhanced track, as I mentioned, it's really the same. It's identical to track 3. It starts off as two-sided risk from day 1 and offers the highest level of shared savings, with 75% of shared savings eligible for day 1 through the life of the 5-year agreement, as well as having the largest maximum loss rate that's capped at 15% of the ACO's benchmark. So now this is kind of a visual depiction of the basic and enhanced track example with a 5-year glide path to risk. And what I did is I showed levels A through E so that you can see how the risk and the shared savings increase each year, as well as a comparison to the enhanced track. So there's really 3 steps that CMS looks for to be able to calculate this. The first thing they're looking for is each year what the ACO determines for selecting their population, because depending if you're choosing the prospective or retrospective assignment, and I'll go into a little bit more detail on that in a minute, that indicates how CMS is going to calculate your population. And the other thing is the ACO has the choice as to what level to start with. So a new or inexperienced ACO might want to start with an upside-only track and may want to start the program at the default level of level A. However, if the ACO has experience in the program or experience managing risk, the ACO is going to benefit from starting off in level E to be able to take advantage of the advanced APM status to be eligible for that 5% bonus and have the highest rate of shared savings with a 50% shared rate. And so it really, again, depends on the experience of the ACO, but the option as to where the ACO can start, they can start at level A, they could start at level B, but then each year the ACO is going to automatically advance up until they stay in level E. So once the ACO determines the level of risk that they want to start and they determine what their beneficiary population is, CMS is then able to do the calculation of the assigned beneficiaries to calculate the total benchmark costs. So I picked an easy example to illustrate with $100 million. The next thing CMS does is then calculate what the physicians, the participants' Medicare fee-for-service revenue is, total Part A and Part B. So in this example, it would hypothetical example of using primary care providers, and let's say collectively those primary care providers, their total allowable charges that they billed was $10 million. And so those are 3 key metrics that CMS would use. So when we look at level A, it's a MIPS APM, and so they're going to have to go through the quality measures and the reporting through the ACO. But their maximum shared savings rate starts at 40%. They have no downside risk and no downside losses. So the downside, there's 0 provider revenue or $0 benchmark at risk, only an upside opportunity of shared savings rate of 40%. Level B works exactly the same way. Then as the ACO progresses up to level C, the maximum shared rate goes up to 50%, and then the loss rate cap doesn't exceed either 2% of the ACO participant revenue or 1% of the benchmark. And so you can see that if it's based on the participant revenue, it's going to be capped at $200,000, or it's going to be capped at $1 million of the benchmark. And so you can financially see what the maximum loss rate is. So it would really depend. Is it a primary care group? Is it a physician group? Or is it a health system group? If it's a health system group, are there providers billing under the same PIN as the health system, in which case the total billing is going to be much, much higher if it's including all the specialists, all the oncologists, and everything else, in which case it's going to cap at the benchmark. If it's a primary care group, it's going to be a much smaller group. So that's why there's really either looking at it as provider revenue or benchmark. And then it progresses up to level D, same shared savings rate, and now it increases, it doubles. So it's either going to be a maximum of 4% of participant revenue or 2% of the benchmark. So it would be a maximum loss rate of $400,000 or $2 million. You're still in a MIPS APM. When it goes to level E, though, now the ACO, all the providers are now eligible for that 5% fee-for-service bonus through the advanced APM. and they reach the maximum loss rate cap not to exceed 8% of the participant revenue or 4% of benchmark. So you can see now it's $800,000 or $4 million. But when it jumps over to the enhanced track, you can see now there's no more cap at provider revenue. It's going to be strictly at benchmark, and so the maximum loss rate is going to be a maximum of 15 million in this example. And again, this is just for illustrative purposes only, but you can see it's a significant difference between going from the basic to the enhanced. When a group gets prepared to go into a two-sided risk year and level, CMS will require that they have a repayment mechanism on file. So typically a surety bond is what's going to be looked for the ACOs. Now, CMS did make some improvements in the final rule to make it easier and year over year being able to keep the same repayment mechanism in place, but it is still something that needs to be looked at and is part of the decision for the ACO as to how they're going to start. So now that we've taken a look a little bit at the basic and enhanced track, I want to go into some of the key terminology and considerations for where CMS defaults the ACO start. So as I mentioned up front, CMS has provided additional flexibility for what it calls low revenue ACOs. And so CMS defines a low revenue ACO as one whose all of its participants together, its total Medicare Parts A and B fee-for-service revenue equal less than 35% of the ACO's benchmark or total expenditures for the ACO's population. And CMS always does the most recent 12-month look back. So it's really 35%. In the proposed rule, CMS had it at 25%, but they increased it to 30% to be able to meet some of the requirements for rural hospitals that won't have the same capital, to be able to go into a higher loss rate, and also to be able to give more flexibility for specialists to be part of physician group ACOs as well. So typically your low revenue groups are physician-led ACOs or small rural hospitals, and high revenue groups would typically be health system ACOs. But if the health system structures their billing TIN so that their primary care providers bill under a separate TIN than their specialists and under their health system, then a health system can also achieve that low revenue status as well. You just have to remember that any changes in billing status typically takes 6 months to get fully into effect, and you're going to need another 6 months to be able to show the patient visits, to be able to show attribution for that TIN. So number one, CMS has introduced what they call low revenue, and if the ACO is not deemed low revenue with total expenditures from their participants is less than 35% of the benchmark, then they'll be deemed high revenue. CMS also looks at experience consideration, what it calls new and inexperienced ACO. And so a new ACO is one where either the ACO's TIN or EIN legal entity has not previously participated in the Medicare Shared Savings Program, and less than 50% of the participants have not participated in the same ACO. So CMS recognizes that more and more providers have participated in an ACO and have some experience, but they may be coming together for the first time where the ACO as a whole doesn't have experience working together. So again, a new ACO is one that the ACO entity has not previously participated, and less than 50% of the providers have not participated in the same ACO in the past. So that's what they're looking for. ACO participants in the same ACO and the new TIN. And an inexperienced ACO is one that the new entity and less than 40% of the ACO participants have participated in a performance-based Medicare initiative. So performance-based means two-sided, which really means tracks 2, 1+, or track 3, or next gen. That's how Medicare would determine that an ACO has had experience in a performance-based risk track. And CMS actually provides the most flexibility to inexperienced and low revenue ACOs. One of the pleasant changes in the final rule that CMS announced last month was for ACOs that are deemed inexperienced and low revenue, the ACO is going to, if they start in level A, the ACO chooses to start in level A, they'll progress to level B, which is upside only, and during that second year, CMS will offer the ACO a one-time opportunity to stay in level B for a second year, allowing 3 years to be in an upside only, basically track 1 ACO, in return for jumping to level E for the remaining 2 years of the contract and the basic agreement. And so what that means is the first 3 years would be in track 1, and then years 4 and 5 would be equivalent of being in track 1 plus. And so that's a nice opportunity that CMS is providing. Now, putting together what all those different terms mean, a new entrant, a track 1 ACO or an experience with risk track ACO, and high revenue and low revenue, this is really trying to show you visually where your starting point would be. So if a new ACO is coming in and they're and they're low revenue, so if a new physician group ACO, they're going to end up with 2 years upside only, and then they're going to have that option in the third year to remain in level B if they choose. Otherwise, they progress 5 years up through level E. And as I mentioned, if the ACO has experience and they've had a solid track record, maybe they've been in track 1 or track 1 plus, they're going to want to jump right into level E and be able to take advantage of that. If they're a new low revenue ACO, they're going to have 2 contract periods. So that's potentially 10 years as a track 1 plus ACO. If they're a high revenue ACO, then CMS has limited them to 1 year as upside only. That's why that July 1st start is an opportunity, because it gives people the opportunity to really think about how to start and do they want to be able to start and have that in an upside only ACO. Now, if somebody's an existing track 1 ACO and they're looking to renew now, CMS is recognizing that they are not going to have enough time to plan to start at a higher level, so they're going to give everybody the opportunity to start in level B. So everybody would have 18 months in level B to go ahead and start. Even though the ACO does have experience as an ACO, it only has experience as a one-sided track 1 ACO. And then as an ACO starts with experience, CMS was very specific in the final rule that any ACO that has experience with risk should not be able to start at a lower level than the amount of risk they're already assuming. Because remember, CMS's goal is to move everybody to risk. And so if they're a track 1 plus ACO, they'll start at level E. If they were a track 2 or track 3, then they have to move immediately to the enhanced track. And all high revenue health system experienced ACOs are also going to move to the enhanced. So the white is visually showing you where there's no downside risk, the light blue where there's increasing risk, and then the enhanced is in the dark blue to be able to show you. And then there is a note right now that ACOs with a date of 2016 or 2017 that entered into the program or track 1 can go ahead and start at a level E to be able to give people more time. So CMS is trying very hard right now to give flexibility, recognizing that anybody who's at its point of renewal won't have had enough time to really prepare for the full risk. So all 221 ACOs who started in 2016 are finishing their third year in 2019. So they will have had a full year's preparation. So when they start into the Pathways for Success and they're after their second contract period, they are going to be moving into the enhanced program. Those that are entering into their second contract that is an ACO that has only been in track 1 is going to be moving into level B. So there's a number of different considerations for new and existing ACOs. So there's quite a few rules. CMS has many, many pages on it, both in the final rule and even under the Notice of Intent guidelines. So if you were to download and look at the Notice of Intent guidelines, there's a 6-page grid that shows you all the different combinations for new and existing ACOs, where their starting point will be, and that shows you what the rules are for a 2019 starter. And again, in 2020, some of those options will go away. All right, so now that we've kind of gone over the two tracks and looked at the levels and where somebody starts, let's talk about some of the flexibility in the program that CMS has put in. So as I mentioned up front, one of the things that CMS allows on an annual basis now is to be able to choose prospective versus retrospective assignments. So what you really want to do is consider if you want your population to grow. For example, if you're hiring new providers, um, and you choose prospective assignment lists, your new beneficiaries will not be assigned during the ACO calendar year. So if your population is under 10,000 and you should be focusing on growth to reduce variation that a small population creates, or you know you're adding new providers, you are going to be best off from the retrospective assignment, where CMS always looks at the rolling 12 months for assignment to the ACO to be able to grow its population. If your providers want a fixed list of beneficiaries for care coordination purposes, or you want to be using telehealth or some of the waivers, then prospective assignment might be your best option. So really understanding strategically where your ACO wants to go each year is what will help you make that assignment. And CMS does allow you to make that assignment on an annual basis, and particularly because if you start at level A, then you don't have all these options available for you as far as how you're going to be choosing your waivers to be able to use until you're in two-sided. So that's why they make it an annual opportunity to be able to make changes. So beneficiary assignment, again, if you're looking for the goal of growth or hiring new providers, you're going to be best off at retrospective. If you're jumping in at a higher level and you want to be using telehealth, then you want to be using a prospective assignment list. Another big change, as I started talking about earlier, is benchmark changes. So HCC, as I mentioned, really positive that they're allowing an annual increase for all beneficiaries. Not as positive that CMS capped the upward adjustment at 3% over the 5-year agreement. So there's no downward risk adjustment cap, but CMS did cap it at 3% over the 5 years and really cited that they did not want it to be a coding game where they reference Medicare Advantage has the opportunity to submit HCC code adjustments. The other thing is the regional adjustment, as I mentioned, that they're going to be making the regional adjustment. And as I said, if you're more efficient than your peers, CMS is going to give 35% of the regional benchmark. If you're less efficient, they're going to start it at only 15% and then increase it over 4 contract periods. If you are efficient, more efficient than your peers, then you will be at 50% of your benchmark having that regional amount blended in and have half of the weight on that by your second contract. So a lot of flexibility in this program. And then looking at a little bit more on the incentives and enhancements. So as I mentioned, one of the things ACOs have now is the telehealth waiver. This really came in through the Chronic Care Act this year, and the Bipartisan Act also had introduced it, which opens it up for the physician fee schedule to include telehealth for the first time and set fees in it. So ACOs in two-sided risk models that select prospective assignment are eligible for a waiver of Medicare's originating site and geographic telehealth requirements. So an ACO no longer needs to be in a rural area to be able to use telehealth and bill for it. But the waiver only covers services on Medicare's telehealth list, so you want to be able to reference the physician fee schedule for that. And services provided in the home are not eligible for the originating site fee. The other thing is the SNF 3-day rule. CMS has gone ahead and included that, which was currently available to track 3 ACOs and to track 1+ ACOs. So now in the basic tracks, C through E, as well as the enhanced track, ACOs will be eligible to use a SNF 3-day waiver regardless of which attribution model they have selected. And then ACOs are also going to have the beneficiary incentive waiver. So ACOs in two-sided risk models, again, the same as the SNF 3-day rule, are going to be eligible for a waiver to provide beneficiary incentives. Now, the incentive may not exceed $20 and must be used for a qualifying primary care service, but it is not limited to $20 a year. It's limited to $20 per visit. And the payments must be made in either a they must be paid to the beneficiary by the ACO, not to the provider, and the can be paid in the method of a check or in an in-kind, such as a gift card. So I'll give you an example. If you were doing nutrition, and you might be offering a $20 gift card to a store to be able to buy healthy foods for the beneficiary. Or it could also be used to help cover the cost of reimburse for the cost of a copay if the patient's, the goal of this incentive waiver is to get the patient to come in quarterly, for example, to be doing lab tests, if that's what's important if they're an out-of-control diabetic. So CMS in the beneficiary incentive waiver, this ACO does have to apply for it. They apply for the 3-day SNF waiver, telehealth waiver, or the beneficiary incentive waiver in advance, and they receive approval. And in the beneficiary incentive waiver, the ACO has to spell out exactly how it's going to be using that incentive, who's going to get it, how it's going to be paid, in what manner it's going to be paid. And then when CMS approves that, the ACO can use that for the following year. So that's one thing why it's nice that CMS has allowed an annual option, because as ACOs mature, they're going to have better ideas on how they want to be able to use some of these incentives and enhancements. I should mention, too, on the incentives and enhancements, CMS, as I mentioned, it has to be paid for by the ACO. The beneficiary incentive cannot be funded by a health plan or a pharmaceutical company, even if that health plan or pharmaceutical company is paying the ACO. That is not permitted. It has to be funded by the ACO itself. Now, CMS also made a number of changes to prevent gaming of the system. So one of the first things that CMS has recognized since the program first started in 2012 is not all ACOs perform equally. We've heard the term ACO squatters. So CMS recognizes that some ACOs came into the program, used the waivers because you had the STARK and the anti-kickback waivers and other waivers as part of the program. So there's been a lot of discussion around were health system ACOs or some groups using it to be able to self-refer, but they weren't actually improving the coordination of care or lowering costs. So CMS wanted to be able to put some rules in to be able to terminate a contract if an ACO, they found that either the ACO wasn't meeting to the quality standards or if the ACO's expenditures were going up. So that's an example of one of the things CMS has changed. CMS recognizes also that year over year, somebody might start an ACO and look to ensure that they meet the new or inexperienced or low revenue status to be able to benefit from starting at a lower entry point, and a lower entry point meaning a lower level of risk. But CMS was very specific in the final rule that they will continue to do a look back each and every year when people add and make changes to their provider list, so that if they become a high revenue or an experienced ACO, CMS will increase the level that the ACO is in. So they will notify the ACO to allow them to make a change. And then if the ACO does not make a change, they will advance that ACO into a higher level of risk, including moving them to the enhanced program if the ACO is to stay in the program or the ACO could choose to drop out. So really some of the changes they have made in here is really doing a further look back for 5 years and that continuous monitoring. Now, at the same token, CMS, there was a lot of comments written in to the final rule with people saying, but an ACO, if you're saying 50% of the ACO cannot have participated in the same ACO, that means an ACO would only have to break itself up into 1 or 2 parts to be able to add on new providers and be able to be deemed as a new ACO. And CMS did respond to those comments and acknowledge that, yes, they do understand that some ACOs will choose that path to both show as reducing their experience or to become new to the program again. But CMS felt that because it puts everybody on that glide path to a two-sided risk, which is CMS's goals, if that's what it takes to align everybody's goals into the program to allow the ACO more time, but puts them on that pathway that CMS wants, CMS is willing to accept that ACOs will create structural changes to meet the classification of low revenue and inexperienced, or a new ACO status. So CMS is acknowledging that, but then, as I said, they did put in additional controls to be able to prevent gaming of the system on an ongoing basis, because that's something that there has been a lot of discussions around, and we have seen, both in the news from many, many sources, as well as probably experience with ACOs, because they're not all created equal. And then the last thing that was actually announced by CMS this week, for any of you that attended one of the webinars, CMS did confirm they will inform applicants of their both revenue and experience status during the application, during the request for information cycle. So an ACO, when they're forming their application, should really look at what is the experience of their participants and how does their ACO structure look like. But if they miscalculate, CMS will come back and tell them during the RFI period, allowing the ACO to make changes either in their participant list or to prepare and accept that they're going to be moving to a higher level of risk, which may require even obtaining a repayment mechanism. So some kind of notes for an ACO to think about and preparing as they go through the application period, whether they're preparing for July 1st or a January 1st, 2020 start, because that will still apply to all ACOs as they start. Last thing I'll just note on the application process is CMS did streamline the amount of documentation that is required for the ACO application process to be submitted. CMS requires the same procedures and documentation and model built as it has in all the past years, but does not require that all the narratives are submitted during the application process. And so that really covers kind of the key points I wanted to put in to really cover highlighting what kind of the overview of the final rule and the highlights of the new Pathways to Success ACO program. And so with that, Sam, I'd really like to turn it over for questions.
All right, thank you, Sheila. I do have two questions here. The first one I have is, what happens if you miss the deadline? Can you still apply the notice of intent application deadline?
No, so if you did not submit a notice of intent, if you're a new ACO and you did not submit a notice of intent by last Friday, then you will not be able to apply for a July 1st start. If you're an existing ACO, you have a renewal process, and I would talk to CMS and your renewal coordinator, or talk to your CMS coordinator and see, because you're still within a week, if CMS would allow you to renew. If you're a new ACO, they have closed down that notice of intent portal window.
Thank you for that. And then we did have one other question. Beneficiary incentive and other waivers. Do you have to wait for the renewal to apply?
It is on an annual basis for applying. And so it is something that CMS had in the notice of intent as part of the application process for the July 1st, but they will open it up again and people will be able to apply for the January 1st, 2020 start. So it's really only going to be, if somebody wants to apply and didn't apply for July 1st, they only have a 6-month wait to be able to put that program together.
Okay. And that looks like all the questions that we had today, Sheila.
Okay, terrific. Well, with that, thank you everybody for attending. It's been a pleasure presenting to you, and I look forward to seeing people at future events. So thank you and have a great day.
Thank you, Sheila. Thank you, everyone, for joining us today. We hope you all have a great day and a great weekend.